Good evening, everyone. We'll just let everyone come in. How's your day been, Robbie?
Hello, guys. It's been good. I was only working a half day today, which is nice.
Ah,
And spent the other half getting my hair cut. So
nice.
all fun and
I can
games,
tell it looks
yeah.
very nice.
Very
Have you
fresh.
been, were you in clinic or what were you doing
Yeah, I
today?
was in clinic this morning, from 8 till about 1. So it was a lovely day. I wish I could just work 8 till 1 every day.
That would be
How was
the
your day?
dream. I have not been working today. Well, I have been doing work, but I haven't been in clinic today. We've got like school is finishing for the summer here tomorrow, so it's been very hectic. Lots of things happening and
Oh,
rushing back and forth, taxiing people around pretty much. That's what I've been doing
yeah.
today.
Well, you'll be getting lots of kids in over if they're breaking up this week.
Yeah, absolutely. This
Well,
is like the
perfect webinar for you.
literally the perfect time of year for this webinar because we all know in the summer, as soon as the holidays hit,
Yeah,
that is it. The kids are all coming in. So I'm sure there'll be lots of tips for people to take from this evening. Lots of people
yeah.
joining us. Numbers are going up. So we will just make a little start. So we've got Robbie with us this evening. So Robbie Stewart, he is a dental therapist. He graduated from Newcastle University in 2018. He splits his week between working as a full scope dental therapist in practice in London and also as a product specialist for NSK. So we're going to hear from him in a little second. Just as always, the webinar will take at least 7 days to go up on the NSK portal on the website. And we will pop a QR code and also a link in the chat towards the end so that you can fill in your feedback and get your CPD form. But without further ado, I will let you start, Robbie.
Thank you. So, guys, welcome to Puzzling Feeds. I know Lawrence has done a little introduction about me, but here's a lovely big photo of me and a little bit more. So, yeah, I graduated in 2018. I've got 6 years of clinical experience in both NHS and private, but I'm just currently working in private at the moment, doing about 3 days a week, and then working as an NSK product specialist the other 2 days. I completed a postgraduate certificate in dental education in 2023, and that was while I was lecturing at Newcastle University, where I spent most of my time on the paediatric department. Another little point in there is that I am currently registered as an oral health therapist in Australia as well. Spent about 5 months over there and doing a little bit of work, which was lovely. Enjoyed the sunshine. So yeah, that's me. So the aims and objectives of this webinar, really, the top and bottom of it is that anyone that's on or listening to this back, I just want you to feel a lot more confident when it comes to examining and creating a treatment plan for pediatric patients. Because I know recently with obviously the changes in NHS regulations and who can open a course of treatment and whatnot, it's kind of all just been thrown on some people. I've been doing it a little while. I was doing some private exams before the NHS regulations came into place as well. So yeah, I'm just hoping to help you guys out a little bit. But the objectives, try and identify key anatomical and developmental considerations in pediatric dental patients, demonstrate effective communication and behavioral management techniques in young patients, assess the caries risk and the dental development, use a structured examination approach, and develop tailored treatment plans based on clinical findings and patient needs, and recognize when to refer. That's the main one I would say as well. So I'm going to split this webinar up into 2 parts. The first part is going to be the examination, and the second part is going to be the treatment planning. So the first thing that I'd say to start off with when you've got a patient in the chair really is the consent. We want to know who can and who can't. So if someone's under 16 and they're deemed not competent, then the following really apply. The only people that can consent are those who are a parent or guardian, or whoever has a residence court order or a local authority that's designated to care for the child, and a local authority or person with an emergency protection order for the child. If they're over 16 or or deemed guilty competent, then they can consent for themselves. And I didn't know this one until recently, actually, but if someone's over 16 but under 18, then the parents cannot overturn the consent, and only a court order could do so. That point is found on the CPC website, and all the links to everything are going to be at the end for all of the references. Next part, I would say, is the history taking. So I'm going to split this up into two, the medical side of things and the social side of things. So firstly, we're going to want you to know the ASA classification of the child. This is actually quite important when it comes to referring and referring guidelines and where you're going to refer the child to, if it's going to be sedation or general anaesthetic, if you have to go that far down the line. Also, in general, most patients that you see are probably going to be ASA class 1 or class 2, so that's healthy or mild systemic disease that's not really life limiting. But when it comes to ASA class 3, then you might need to rethink of what treatment you can do in the dental practice. So, for example, someone who's got really poorly controlled epilepsy, they'd be classed as class 3 or 4, depending on the severity of the epilepsy, and they may need a CDS referral to the community if you can't provide the treatment in-house, because if they're so uncontrolled, you don't know when the next seizure is going to be, and so on. While we're talking about CDS referrals and medical histories, there might be some other cases where you're going to refer your patients to the community dental services, and that would be really if they've got severely unstable medical conditions where, like epilepsy in that situation I just said before, they're not able to have the treatment in practice. It could also be that they have a severe learning disability or they need 24/7 care, and you're really not able to do what you're required to do at the appointment. If they're needing further work done, like fillings, extractions, then it's not suitable to do in practice. Complex medical conditions, so the likes of haemophilia, anything that's really going to need input from a specialist, you might be better off referring to the community dental services. And I've got down here some specific conditions with dental implications. So there's an array of those. You could go on forever with those. But I just want to point out some key ones where if anyone flags up with this on like a prerequisite form before you see them, then it's just little tick boxes in your brain for what you might be expecting to see. So the first one I've got down is Down syndrome. So Down syndrome, we can have delayed eruption, we can have hypodontia, microdontia, and associations with periodontal disease. We've got cystic fibrosis. So cystic fibrosis, there's links to enamel hyperplasia and celestomia. Type 1 diabetes we'll be aware of, increased risk of caries, there's increased glucose in saliva, and epilepsy, we've got the medical side effects from the likes of phenytoin. Leukemia, we're going to be looking out for oral ulcerations, increased gingival bleeding. Sickle cell anemia, we would potentially have delayed eruption associated with that. Ectodermal dysplasia, we could have hypodontia, conical teeth, and delayed eruption. And the final one, cleidocranial dysplasia, we could have ICOS, supernumerary and delayed eruption. Yeah, so there's quite a lot of things to think about when it comes to the medical side of things. So when people come in and they want to just rush that medical history, really take the time, especially when it's a new patient and you've got no idea of the background. And then we go on to social. So we've got the likes of living arrangements, diet, smoking and alcohol intake, birth history and dental history. Obviously, these vary depending on how old the child is. If you've got a 16-year-old, then you may be looking at the smoking and alcohol a little bit more. Birth history, you're looking at those who come in potentially the first checkup, the 6 months old man wants to get them checked over. We want to be making sure that how the birth was, if there was any complications, because that can give us a little indication as to whether we might be expecting some dental abnormalities in the future, especially potentially hypermineralization. The next thing we're going on to when we're doing an exam really is the complaints. So really, if we're trying to do an assessment of someone, let's say, is in for an emergency, they're complaining of pain, we're going to be looking at the 5W model. So who, what, when, where, why, and how. Firstly, we want to know who first noticed this complaint. Was it the child? Was it the parent? You know, some people come in, the man will be like, oh, you know, we've noticed a little black mark on his tooth. He's not had any pain. And then you do the assessment and you realize actually it's a MOD cavity with an associated abscess. And that's the way it is. What does it feel like? What makes it better or worse? We're trying to get a description of the pain here, whether it's sharp, throbbing, or aching, and to see what stimulus makes it worse or better. And that can have links to, I guess, when you get in the description of the type of pain as to whether it's like pulpitis, irreversible pulpitis, or it could be some form of periradicular pathology around the tooth. When did they or the parent first notice the pain? And when does the pain happen most? Is it at night? Is it a gradual onset? Or we're trying to think about, you know, did this happen after he smacked his face on the floor? Is that a reason why there's the chipped tooth and the pain? So you're just trying to really get the history behind all of that. Where exactly does it hurt? So, and where is the pain spreading? So we're trying to see if it's a localized or generalized pain here, if there's any potential for infection to be tracking elsewhere. Is it radiating towards the ear? Is it happening along the jaw? Little telltale signs like that. And why? So why do we think it's hurting? Is it an indication to their own thoughts, or was it trauma? Have they been eating lots of sweets, lots of fizzy pop? The parents will maybe shy away from admitting to that. But some of the children, especially 5-year-olds, will be the first ones to tell you. And then finally, how? So how bad is the pain and how long does it last? So we want to know, we're trying to get a pain scale here. So is it 3 out of 10 or is it a 10 out of 10? The next thing we're going to move on to is the extra and intraoral assessment. So we do these on everyone. So this shouldn't really be anything new. We're going to start with the extraoral assessment. So actually just taking a first look at the child for head and facial appearance. We're looking for any asymmetries or association with systemic conditions. The skin, is there any bruises? Are there any viral lesions? Are there any growths? And again, that can come into safeguarding as well in terms of bruising, whether it's in a easy to bruise place or not. Yeah. Eyes. So is there any jaundice? Are we thinking that there's any other systemic condition going on here? Do they have a visual impairment? And then going down to neck. So we're going to be palpating for any nodules, lumps, or bumps, and then assess the TMJ. So we're getting them to open and close. We're assessing if there's any clips or deviations. Then feeling the muscles, making sure that check for the muscles of mastication, if there's any hypertrophy, or the potentially clenching and grinding. And then gland. So looking for any swellings, especially around the parotid gland. I feel like there's recently been a big spike in mumps at the moment, like big glands and facial swellings, which is quite wild. Then we're going to go on to the intraoral assessment. So we want to be checking out the soft tissues, ulcerations, white patches, also check for any lacerations within the mouth as well, especially if there's been any trauma involvement, or even if there's not, it's just good to note down anything that you see. The OH status, so check to see whether they're brushing the teeth, whether it's once a day, back control, calculus, all of that. BPE, we might only, if you're a modified BPE, depend on their age, which would include only doing it around upper right 6, upper right 1, upper left 6, lower left 6, lower left 1, lower right 6. Then we're going to do a full chart, assess for any caries, fracture, or any abnormalities. And we're going to assess the development stage against the age of the patient. So are all teeth there that should be there? Is there any ectopic teeth? Are we worried that there's delayed development? And finally, occlusion, which I know is a fairly new one for us in terms of assessment for, well, I know when I graduated, I literally learned hardly anything about things, maybe what class 1 was, the class 3, but didn't really look at the intricacies of such. And especially when you're examining children, that is a huge topic. So a little bit more about orthodontics and occlusion. My advice is just say what you say. So these are the things on this the bullet points that are assessed on the IOTN scale. So we want to assess the overjet, and how are we going to do that? We're going to use like a Williams probe to measure what the overjet is, or reverse overjet, depending on which way it is, if they're class severely class 2 dip 1, or if they're class 3. We're going to assess for any crossbite. So I hope you can see my mouse, but this photo on the top right, you see the obvious crossbite on that upper right too. Displaced contact. So displaced contact is basically, we would usually use the word severe crowding or spacing. We would be measuring, so if you can see my mouse on here where you've got this buccally excluded canine on the upper right, we would be measuring the displacement of the contact from where the point of contact should be to the neighboring tooth. So let's just say, imagine that could be up to like 7 to 10 millimeter contact displacement there. Then we're going to want to know if they have an open bite. We'll assess the overbite as well. So that's usually measured as a percentage. So it could be, let's see if we've got one here. So I'd say this one on the after photo on the top right, that's about, I'd say, maybe a 40% overbite. So if it was 100%, it would be fully encapsulating those lower incisors. And then you can have a traumatic overbite whereby the incisors dig into the soft tissues. We're going to be noting any hypodontia or hyperdontia. We'll be assessing for impeded eruption of teeth. So this is quite, well, I wouldn't say commonly, but in my experience, this used to happen if we placed sometimes stainless steel crowns on A's. Then this was before the 6s erupted, and the 6 would come in and it would get stuck on the ledge of the stainless steel crown. Sometimes you can just put an orthodontic separator in and it'll fall back into place, but other times you might need the crown removed, or an orthodontic opinion. Again, impeded eruption, that can also happen if they have had, let's say, D's or E's extracted and then the 4s or 5s can't come through in the right position and get stuck. Posterior lingual crossbite, so that's down on this bottom right one. You can see how the upper buccal cusp is occluding to the central fossa of the lower 6. Cleft lip and palate, that's usually an instant referral. Submerged deciduous teeth, that could be an indication of missing successors or ankylosing to the bone. partially erupted and impacted teeth. Now, main ones to shout about on this point are ectopic canines. So canines that haven't come through usually by the age of 10 are red flags. And then supernumerary. So if there's any supernumerary, you want to note those down and potentially so this slide has got a lot of information on. On the right, where we're looking with these 1, 2, 3, 4, and 5 scores, so it goes 1 to 5, and we can see down here all of the points that I was talking about before. And then if when you're measuring and comparing, it gives you the score that patient will be in. So if their overjet is 3.5 to 6 millimeters, then they score a 3. But if they had an overjet of, let's say, 6 millimeters, and they had displaced contacts of 4 millimeters, then we would instantly be at the high level, which is 4. You can see down here, partially erupted, tipped, and impacted against adjacent teeth goes straight to the number 4. On the left side, we have the British Orthodontic Society's quick reference guide, which is so handy. It would be really good if you could get this printed off. Again, the link will be at the end. But if you could print this off and have it in surgery somewhere, just as like a quick flick back to, so you know what you're looking out for. It's got the normal development and indications for referrals. So it's important that when you're looking at what normal development is, you're looking for any signs that are abnormal. So let's say if they're in the deciduous dentition stage, we're not looking out for, oh, we're going to give them fixed braces right now, because that's not appropriate. What we would be looking out for is if there's this, like on here, it's the severe skeletal discrepancy. So if they're, severely class 3, and then we might be at least having the idea that we're going to have to refer earlier than what we would for, let's say, someone who was class 1 with moderate crowding for an opinion from an orthodontist, because they might use different appliances, or potentially they might even need surgery at some point. So you want to get that referral done. When you're referring to your local referral site, they usually have a pro forma. And on that pro forma, there might be somewhere on specifically that says that you're referring for advice only. And when you're referring for advice only, you're probably referring for if they're at increased trauma risk. So that would be if they've got a severe overjet. If there's any disturbed eruption, so if we've got any supernumerary teeth, anything that looks off to what was normal. And also if you're asking for advice regarding interceptive extractions. So this one comes into play, especially when you've got poor prognosis 6s and you're wanting to lose those at some point. You want to get a referral to orthodontists to advise so that they can make an assessment on their occlusion and to whether to delay the extraction or do it at the right age, which is around week 10, and that's when the bifurcation of the roots of the 7s is occurring. Usually, but everyone's different. Again, you get an opinion for that. Yeah. Next up, we have special investigations. So the main ones that we're going to come across are radiographs. So radiographs are always patient dependent. There's 2 guidelines I'm going to look at here. So there's the European Academy of Paediatric Dentistry and the Faculty of General Dental Practitioners. So the first part, EAPD, so special investigation specifically for caries. They state that really, regardless of the caries width, there's usually no specific reason to expose between the ages of 10 and 12, and that's due to exfoliating teeth, 4 by rings. They say that at high risk, this should be taken every 1 to 2 years, and low risk, anywhere between 3 and 10 years, which I know 10 years is quite an extortionate time frame. And that's again why these are guidelines being your decision based off the clinical assessment. They do say don't attempt to expose the child if the child won't tolerate it. So we're not doing any of the quick put this in and quickly try and run out while they're wiggling in the hope that you're going to see anything. Because if there's any movement when you're taking that bite wing, you're really not going to see anything. It's going to be classed as unacceptable. They do advise taking an OPG for the second line of defense for parents assessment. So if they can't tolerate the bite wing, then OPG it is. These are, well, this is the chart that I took directly from EAPD. Again, the link will be at the end. But you can see after you've done your initial assessment for the bite wings, if the child is deemed clinically necessary to have bite wings, then depending on the age, the stage of dentition, and what was initially detected in the bite wing as to how frequently they should be having those retaken. So you can see over 16 years old, permanent dentition, there was no caries noted at all on the bite wings that you initially took, and they say around every 5 to 10 years. Whereas if you are 3 to 7, primary dentition, and there was caries in the outer third of the dentin, then take them around every year. So, what the F did he say? So, for caries and development, starting with the caries, if they're high, moderate, or low risk, we could be doing intervals of anywhere between 6 to 24 months. When you were taken intraoral film, they are advised for trauma. So we're talking periapricals here. So trauma, always for a baseline. If there's any localized ectopic teeth, and submerged deciduous molar in 1 quadrant only. Then they state OPGs to be taken if we've got missing lateral, poor prognosis 6s, and submerged deciduous molars in 1 or more quadrants. Now, some other special investigations that you might come across are things like vitality testing, electric probe testing, ethyl chloride, and testing percussion. So radiographs aren't the only thing, but they are usually the main ones to go to. So how are we assessing what the caries risk is? So are they low, moderate, or high risk? This is taken directly from NSK resources. So we have 3 categories here. We've got the contributing conditions, general health conditions, and clinical conditions. So within those subsections, you can see have we got visible plaque? Do they have any special healthcare needs? And are they having a sugar drink? Now you've got lots of different ones, tick boxes. You have to kind of gauge where the patient's going to be, because someone could be having fluoride exposure, but then they're also having lots of fizzy drinks. Well, I would always put them at the higher end of the category, rather than the lower end. We've got different ones for different age stages. So we've got 0 to 2, we've got 3 to 6, and then we have 7 to 18 years old. Coming on to abnormalities now that you might see. Now, these are just some ones that I've seen when I've been practicing, and there's an array of abnormalities out there, but I just wanted to pinpoint some ones that you might come across a little bit more frequently. So we've got hypermineralization, so you can see on the top picture, hypermineralized 6, and then you can see the patches on the anterior teeth here on the bottom. So hypermineralization has a prevalence of around 3.6 to 25% of people in Europe, and it's a reduced quality of the enamel, and it's termed hypermineralization when the enamel is of normal thickness, but not fully mineralized. What's the cause of it? Well, there's many points to say it's related to many different things. There's still a lot of research going on. That's why you want back to the history again. We've had traumatic childbirth, infections, that sort of stuff. It's pinpointing towards these reasons if they do have any of these clinical signs present. Again, I did mention this before, but around the ages of 8 to 10 for extraction and stage closure, if they've got poor prognosis sixes due to hypomineralization. Next up, we have hypoplasia. So, hypoplasia is a reduced quantity of enamel, which results from small or irregular shaped teeth, which may be pitted, thinner, or smaller in size. So usually with hypomineralization, the tooth actually looks the same. It can have post-rupture breakdown and crumble eventually. With hypoplasia, usually when they're rough, they do look a little bit different. Turner tooth down here is a result of some infection around the deciduous tooth, which caused disruption in the enamel formation. And amelogenesis imperfecta is a version of hypoplasia. Next up, we've got hypodontia, so that's missing teeth. Hypoglossals, again, both of them can actually have hereditary links. So it's just good to get that history from the parent, you know, if they've got any hypodontia history or smaller laterals or any smaller teeth. And then we've got gemination, which is it occurs when the developing tooth tries to split or divide itself, and it results in the formation of two partially separate tooth crowns fused together, and it creates a single enlarged tooth that appears to be two combined teeth. Fusion can be clinically similar, but fusion is the union of two embryologically separate developing teeth, whereas gemination is the incomplete division of a single tooth bud. And it's usually radiographs that would help differentiate between the two. Now, trauma. So, lots of different things. I actually really love this diagram because it's just so nice to see what you're actually talking about rather than being a descriptive point. So there's many different types of trauma. There's two peaks of incidence that this trauma can happen in boys, usually at the ages between 1 and 3 and the ages of 10 to 12. And whereas in girls, it's usually between the ages of 1 and 3. Now, the 1 and 3 age is usually when we're finding our feet, we're crawling, walking about, falling, bumping into things. But the second spike, which is usually in boys, is because of the increased incidence of contact sport. And also to note that children with procline teeth are at higher risk of trauma, which is another reason why they should be seen early when doing an orthodontic referral. And we've got this nice little trauma pathway. So weekly fencing, you know, the patient can there's displacement of the tooth. It's wobbly. If only one tooth and there's no root fracture, then that would be extrusion. If there was a root fracture, then the diagnosis would be root fracture. This, again, really nice to have in surgery and the link for the end. Now, with trauma, there's many steps in assessing the trauma, and always key to take a radiograph so you've got that baseline so you can then refer back to if there's any periapical pathology around the tooth at a later date, or whether if it's a deciduous tooth, if it's become intruded into the developing tooth bud, and there's pathways on the IADT, the International Association of Dental Trauma, for each individual diagnosis. So I hope you're also with me when we're going on to part 2, which is treatment planning. So yeah, let's hit it off. First stage for behavioral management, I would say the key takeaway here is treat the child, not the tooth. We've probably heard that one before. we've got many different methods for behavioral management, whether it be non-pharmacological or pharmacological. So the list as seen here. I'll go into the pharmacological ones a little bit more. So you've got nitrous oxide, which is used as inhalation sedation, conscious sedation. It's indicated for mild to moderate anxiety and short procedures. It's got a fast onset and recovery time, but it's not effective on under 3-year-olds. Then we have IV sedation, which is the usual drug for that is midazolam, usually for longer procedures, children with really high anxiety. It has a fast onset, longer recovery time though, and it's only to be done in a specialist setting if the child is under 16. Then we've got general anesthesia. So that is for extensive treatment and for those with severe anxiety or phobias. It's at least a predictable outcome. You know they're going to go to sleep. You can get the treatment done. But there's a longer recovery time with post-op nausea in some cases. Very important to tell your patient about really operative instructions if you work in that kind of setting, if they're going to go for a general anesthesia. So when we are treatment planning, usually at the end of my notes, what I would have is after an exam, I would have treatment plan, and then I would always have prevention. So in the prevention, I would then line it up with what the DWH recommendations are. So you can see here, I've categorized them into the different age groups, what's recommended for all in the green, what's recommended for those of high risk within that category. Again, I'm not going to go through all of them, but key points are mainly for high risk people, reducing the recall, fluoride varnish more than twice a year, so usually once every 3 months. And then those who are over 10, giving out the 2,800 parts per million toothpaste, or over 16, the 5,000. So, conservation. We are going to be looking at material selection when we're doing this, because not every material is good for the job. I've put all of them on here for clarity. I know we're not really going to be about them anymore, but just to compare it to the others. So obviously it's really strong for aesthetics, very brittle. Then glass ionomer, so that might be GC Fuji4 with a moderate compressive strength and a low bond strength. Then we're moving up to resin modified glass ionomers. So that might be SDI's Riva Light Cure. Now this has got a better bond than glass ionomer, and it's got a moderate compressive and flexural strength. Then there's Compomer, which is the likes of Dentsply Direct. It's like a resin modified GIC, but better aesthetics, but it does require bonding. And then we're going on to Composite, which we have as a really high compressive and flexural strength. Good aesthetics, as we all know, but very technique sensitive. The shrinkage on polymerization can also cause micro leakage and sensitivity, which will probably become accustomed to with done filling and lesion comes back like, oh, I've got so much sensitivity. Stainless steel crowns, these are extremely strong. You can do with minimum to no prep, and it's just very, very superior when it comes to longevity. These will probably last the full lifespan of the deciduous tooth. Also on here, sorry, not on here, but what I should also mention is that there is a product on the market called Riva Star, and this is silver diamond fluoride, and that is absolutely amazing for children who are maybe pre-cooperative or not engaging with the likes of high speed, slow speed, the dental equipment, because this can just be isolated with a little bit of cotton wool and painted into the cavity, and will turn the cavity black and completely arrest the caries. So it's an excellent tool to sort of maybe delay someone while you acclimatize them and eventually get to the point where you can place a restoration, or even if it's just going to eventually prevent them from having a general anesthetic. So extractions, weighing it up. There's many things that might influence whether we're going to take a tooth out or not. These things come from the likes of age. So how long does that tooth need to be kept for? Is it just to maintain space? Could it be left if it's asymptomatic or if natural exfoliation is close? It's already mobile and it's got a DO cavity in it. I'm not going to go in trying to prep the tooth. I'm going to leave it to exfoliate on its own. Root resorption. So if the root is resolved, then it's probably not going to need to be taken out. Because like I said, it's going to naturally exfoliate very, very soon. The only time that might be slightly different is when there's infection. So if there is perioradicular pathology or an abscess associated with the tooth, then I would be extracting. If there's trauma, then we're going to look at the guidelines, but if there's severe luxation or severe fractures, then extraction might be what is deemed appropriate. If we have delayed eruption, then we might want to take out a tooth to help the successor come through. But again, we would want an orthodontic opinion for that. I took out many things that have just been hanging in there forever until the patient's practically ready to have their bond up done for the fix off on it. And then medical history. So if someone's medically compromised and they've got deep caries with questionable pulpal involvement, then an extraction might eliminate and reduce the risk of them getting infection, especially if they're high risk for sepsis. But on the flip side of that, if someone is, like, say, has a risk of bleeding disorder, then we're probably maybe going to take a little step back from the extraction, and that might be a case where we need to refer. So now we've got some cases coming up. So get your pen and paper ready. Pen that are sitting in finals again. So the first one we've got is Grace, 5 years old, attending with mom, first ever visit to the dentist, and medically fit and well, brushing once a day, classic strawberry toothpaste. Diet, we had an occasional fizzy pop, and the complaints, well, mom noticed discoloration of the front teeth. We'll get a little bit of background to that. We noticed that this was a few months ago, and we have since been trying to brush the black marks off. Grace did have some toothache a long time ago, but mom thought it was normal teething. Compliance, Grace is not very compliant. Grace is already crying in the surgery, sat on mom's knee. But luckily, you get to have a peek inside. And this is what we see. So we have A to E present upper and lower. Assessing the soft tissues, their oral hygiene. So we've got a bit of black around margins. And then we'll start with the obvious. So caries or here, and probably caries in there. Then down here, on the lower left knee, we've got caries with associated sinus. Distal caries in the thing, MO and DO on that lower left knee. And what would we be wanting to do here once we've seen this clinical picture? So we're definitely going to be wanting to do some x-rays. Ideally, want to get some radiographs. We're assessing for depth of caries and any perioradicular pathology in between and around the space between the bifurcation of the deciduous roots and the developing tooth bud of the successor. We might also be doing some percussion tests. That'd be on that upper right knee. I probably wouldn't want to touch that lower left ear because it just looks uncomfortable. And then again on the lower right ear. So the percussion has given us an indication of whether, again, then with that pathology between the space, because pressing on the tooth is going to cause discomfort. Well, yeah, that's what we've got going on. What are we going to do? Well, like we said before, we want to start with prevention. I forgot to note, obviously x-rays weren't taken for braces because there was no cooperation there. So then we have to deal with that as part of the treatment plan. So looking at it as a whole, I would say the prevention, we're going to follow DWH guidelines, OHI, fluoride bonding, diet advice, and a reduced recall. In the intervention, we're going to want an opinion from a GP for prescribed antibiotics, because there's absolutely no way that we're going to get any forceps on that tooth anytime soon. And when we're going to do the referral to the community dental services, it's going to be a little while. So, and I highly doubt we would Grace be going for inhalation sedation. Let's say happy days, Grace came in and she was amazing. There could potentially be a chance of us doing some stainless steel crowns on the lower beams and the upper lip, and then just doing an XGA of the remaining areas too. When I worked in Newcastle Dental Hospital, there was often times when we would have plans for children to go for XGA of multiple teeth, because the cooperation was really poor. But as they acclimatized and were coming through the student clinics, we actually were managing to put some sets in, save a couple of dings, save a couple of ings, whereby we built up that trust with the patient and managed to reduce the amount of teeth that needed taken out, which was just excellent. But that's not the case in every practice, and I totally understand that, especially in NHS, it's very much in, out, get the job done as quick as you can, doing the best care that you can as well, but in a shorter time frame. Now, the second case we have here is Paul, who's 5 years old, attending with Grandma to an emergency appointment. It's Paul's first visit, and Grandma says that Paul keeps complaining of pain on the upper right quadrant, and it's keeping him up at night. So that's all the information we've got so far, but what more do we really need? Well, we firstly want to find out who has parental responsibility, and we need to take a further history of the complaints, medical, and all of that. So we'll find out that Grandma has a court order, so she's capable to consent on Paul's behalf. And we're using this model to assess pain. So who noticed the pain? It was Paul. What does it feel like? It's an ache and a throb. When was it first noticed? When does it hurt most? So it started 2 weeks ago, and it hurts most at night. And where does it hurt? So it's just around that tooth. And why do you think it's hurting? Well, Paul ate something really crunchy and felt like crap. And how bad is the pain out of 10? It's a 10 out of 10. Further history taken shows that Paul has got a very sweet tooth and loves some jelly babies, and is only brushing once a day with Grandma's classic whitening toothpaste. Medically fit well. We find out that actually Paul broke his arm last year falling from a climbing frame, was hospitalized, but Grandma said he wasn't phased after the event at all. Clinically, this is what we're seeing. So we can spot the caries, soft tissues. Now, what are we going to want to do here? We're going to want to try and take some radiographs. So first up is some lovely bite wings. Now on here, see they're both acceptable bite wings. We're looking at good bone levels. We've got an unerupted 6 here, and then stating the obvious, we're starting with this huge carious lesion on the upper right wing. We've got focal involvement. Now, with this X-ray, we actually can't fully say and assess if there's any periodic pathology there. So we maybe want to take a video or OPG if we wanted to confirm that. But realistically, there's only one treatment option for this tooth anyway. Then we're going around spotting other caries and the other teeth, the left, and right. What is our treatment plan going to be? Well, let's have a look. So actually the diagnosis, we've got irreversible pulpitis of the upper right end. Caries as no diagnosis. Prevention, following DWH guidelines, and then the intervention, we're going to try to do some stainless steel crowns on the upper left A, lower left A, lower right A. A composite film on the lower left D. You could also crown it if you wanted to, but it's minimal, so composite would be fine. And then extract the upper right A. Now, this was Paul's first visit now seen for an emergency. Based off the history that grandma gave me, the first thing I probably would try to do is take out that upper right A, just based off the fact that it's 10 out of 10 pain. You want to try and give it a solution to the problem immediately. While I was there numb enough, I'll probably try and put in some sets for the teeth I was planning on crown. But obviously I know that can't all be done so quickly. We don't know what it's going to react like, but happy days, let's say, gets on with it and job's a good one. Last case 3, we have a 14-year-old female who attends for a routine checkup with a regular attender at previous practice. No complaints, fitting well, and a frequent snacker and brushing twice a day. Clinically, we are seeing this. So, in one spot, what's going on? We've got probably 7, 6, 5, 4, 3, 2, 1, 1, 2, 3, 4, 5, 6, 7. So yeah, we've got that retained upper right C and an ectopic upper right 3. So where is it? What's going on? We want to know. We want a radiograph to assess that. We're going to do an orthodontic assessment. We're going to measure the overjet. We're going to measure the contact displacement between those teeth. This is a kind of typical class 2 appearance, whereby it's slightly flared laterals, increased overjet, and then retrocline central incisor. We managed to do 4G, this is what we find. You can see we've got some developing needs, both there, retained C, and medially tilted and impacted upper right 3, which is pressing things into the of that one. Now, cases where this where missing 3s go unseen clinically, it can have quite detrimental effects against resolving the root of the lateral incisor. So it is really key that we're always palpating buccally around between the 8 and 9 years, feel for those the canines that are there. Treatment plan, prevention, where low care is, and intervention, we're going to refer to the orthodontist. Now I've got on this slide just some tools for the job, and I thought I'd mention is to be fair, I didn't really go through hygiene that much. Not something that you massively see in terms of cartilage buildup or periodontitis, unless they're medically or systemic disease that would influence that. But air polishing devices like the NSK Ikigai really good with the softer powder to get around orthodontic appliances and keep everything nice and clean, and just generally good for biofilm disruption, as we all know. This is SDI's Riva Star, which is the silver diamond fluoride, amazing at arresting caries. It can have a little bit of a taste, and it does stain. If you drip it anywhere, it will have a really dark stain on the clothes, on the lip, for a while. Well, on clothes forever, but on the lip for potentially cutting. And then I wanted to mention the miniature heads for the air turbines, which is amazing for getting into small children's mouths. Could I say? If you're trying to do a crack one in the E, you know what it's like when you've got a normal sized turbine head. You're trying to get them open as wide as they can. It's just not working. The NSK's X Max Eco is really good, small head, and you use either short shrimpers and just some with the wow. I mean, happy day. So a little summary as we come to the end. Always treat the child, not the tooth, and don't be too hard on yourself because children are always going to be children. You could have the best treatment plan in the world and it might just fall apart. Ask for a second opinion if you're in doubt. There should always be someone around to help you. We're meant to be working as a team. And always just say what you say for ortho. And again, get an opinion if you need to do so. The references, these will all be available when the webinar becomes available in a week's time. But if anyone needs them sooner, you can always let me know and I can send you them. And thank you. So I just wanted to put my details here. My Instagram and a 40% off NSK code. We've got 2 QR codes here. So the one on the bottom right is so that you can get your CPD. There's a questionnaire and some feedback would be absolutely amazing as well. And then this top right one is a fundraising link because myself and some of the Ikigai educators are actually heading to Tanzania in January to do an oral health education outreach project, whereby we're trying to get communities together and educate them about good oral hygiene habits and yeah, in line with the government, because they're trying to stop oral mutilation, which is not very nice. But all of that information is on that QR code. So thank you all for listening, and I hope you really enjoyed it.
Thank you so much, Robbie. That was fantastic. If you are not able to scan the QR code, if you're on your phone, maybe, there is a link in the chat as well, that you can click and you can go on and claim your CPD certificate. We have had a few issues in the past of too many people clicking at once and it freezes and whatnot. So just take your time. We're going to do some Q&A as well. Pop your questions in the Q&A box. I will just have a little look and see. So we've got a question already. Let's see. So Robbie, someone is asking, for pediatrics, do you regularly use the simplified BPE?
Yes, always. So if the simplified BPE is a tool that's available because they've got the 1s and the 6s that are erupted, then always do the BPE, yeah.
Fab. Someone else is asking if they could have a list of the references. Maybe we could pop those on the Ikigai group or something like that for people to access. Would that be okay?
Yeah, definitely. Yeah.
Great, perfect. Good, good. Any more questions? Just pop them in the Q&A. I think that was a really good overview, Robbie, of all kinds of things, because sometimes you can, you might get a 12-year-old in and suddenly you realize, they've not seen a dentist in a while, they've got a missing 3. And that was a really good guide of, what to do in that situation, because I think it's sometimes just not knowing what to do can make you almost freeze from doing anything, right? So
yeah.
I think you mentioned about working in a practice where you're really well supported as well, and you have colleagues that you can touch on, because no one's going to, I think I saw a post the other day of someone saying, will I get in trouble if I do a referral and it's not right and things like that. Like, you're never going to get in trouble because they will get to the right people and they will get seen. So I don't know what you think about that.
Yeah, well, I think it's I've seen the was it Jason Wong who put forward about referrals and stuff. Yeah, I think always best to refer. And if you feel like the referral might not be necessary, then always asking someone in the team, because someone else is going to have the experience of that. Yeah, go for it. And the referrals actually seem really daunting. I remember the first time that I started doing referrals, I just seen this big, horrible NHS text box with loads of ticky boxes and this and that and patient info, and it was really not user friendly. But then once you've done it like once or twice, it just becomes second nature.
Yeah, awesome. We've just had a flood of questions now. So someone's asking first of all how to access the Ikigai group. So on Facebook, if you type in Ikigai Oral Hygiene Community, it will come up. It's a group you just ask to join and we will let you in. We usually ask about your GDC number and stuff just to make sure that you are a dental professional to get in there. Or you can follow us on Instagram as well. Ikigai Oral Hygiene, I think is the username on there. Someone else is asking, sorry, didn't hear what age you said to be referring poor prognosis hypoplastic 6s to be considered for XLA.
So they consider those for XLA at around the ages of 8 and 10, which is when they should come out. So really, as soon as you see that the 6s are through, and that you can see that they are hypermineralized and there starts to be any signs of post-eruptive breakdown, then you'd probably be wanting to refer. It depends on the waiting list as well, because NHS you're going to be waiting potentially a while. So sometimes you could get in contact with the orthodontic practice, ask what their waiting times are. Some of them do have fast tracks, so if you are referring for advice for prognosis 6s, they will get sent to like a different clinic with a that I'm looking for higher priority. But yeah, so the 6s are coming through around 6, 7. You notice that there's they're kind of breaking down, then I'd probably be referring them at around that age, like 7 years, because you could potentially be needing to take them out between 8 and 10.
Brilliant. In regards to referrals for inhalation, sedation, or GA, do you put these through yourself or do you have input from the dentist as well?
So I would send all my community referrals myself. You can take what the preference is and what you've discussed with the parents in terms of what treatment might be offered to them. But when they get assessed at the community dental services or at the dental hospital, whichever they go to, it's up to the kind of whoever's running that consultant clinic or whoever's the SHO doing the assessment.
Awesome. How do you explain Riva Star Aqua to parents, and can you use near the pulp?
So Riva Star, I would describe it as something that is got a high strength silver and fluoride in. It kills all the bacteria, it arrests the decay. It will unfortunately turn the cavity black, which you have to consent for. At the hospital, we used to make sure we got written consent for that. And then if it's too close to the pulp, then I wouldn't be using it because it wouldn't really have much of an effect, because once it gets so close to the pulp, there's a likelihood that the tooth's got irreversible pulpitis, especially if it's symptomatic, then you have to assess the symptoms for that.
Bit of a patient management question. So someone's asking, how do you explain to the parents that once you start pulling a tooth that you will need to finish without stopping?
Well, actually, I have had an instance where I've had to stop when I started pulling the tooth actually. So I guess you try and tell that to the parent, but if the parent's there saying no, stop, then you've got to stop. But you just try and sit them down and say, when I show them, demonstrate with the straight probe that the tissues are really nice and numb, shoving that probe right down, breaking any of the PDL, but it's obviously demonstrating to the parent, all right, yeah, the local anesthetic's definitely working. And understanding that actually it's the pressure that the child's not coping with rather than the pain. However, there is instances where if someone has infection or irreversible pulpitis, then they can have what we call hot pulp, and often in those cases it does take a little while to settle down, and the local anesthetic doesn't always numb it up, so you might need to do supplemental injections, the use of orthocaine, Intraceptal, or if it's an open cavity.
Yeah, perfect. I'm sorry, a few more questions on silver diamine fluoride. People are very interested. Do you have to do any prep before using SDF?
No, but you ideally want the cavity to be cleansable. So if you've got a broken cavity, like the DO, it's fairly large and open. You know they're going to be able to get a toothbrush in there, or you can give them a single puppy toothbrush and tell mom, make sure you clean inside there. Then yeah, that's fine. But you couldn't really place it if it was on a proximal wall, because one, you need access into the cavity, and two, then you wouldn't be able to do the cleaning. You would just get secondary care.
Great, thank you. Someone's asking, any tips for taking radiographs in small mouths?
You can get size 0 films, which are smaller than size 1, which are really good. Failing that, sometimes it means of young cough tolerator, or the little bite cards. But actually, I forgot who does them or where you get them from. I haven't used those in a long time since I was actually training.
Good that you said that, because they're also asking where to get the bite wing tabs from. So
Sorry guys, I don't know where to get the bite.
We'll try and find out. We'll try and find out. What material do you use to dress a tooth if you're unable to extract on the day?
Often I wouldn't dress the tooth. If I couldn't extract it on the day, I would leave it alone. If there's signs of infection out there, then I would be asking. If it was a failed attempt of the extraction, then I'd probably be asking the GDP, whoever's around, to potentially grab antibiotics for appropriate.
Great. We'll just do a couple more because we're running out of time. Let's have a look. Do you ask a dentist colleague to report on OPGs you take? I believe dental therapists are unable to write a report on an OPG, but happy to be corrected.
I've been writing them myself, so yeah, I think it's just knowing what normal anatomy is, what abnormal anatomy is, and knowing that what was the reason for the exposure. Well, the exposure was for caries assessment and peripathology development. So if you know what you're looking for, because you wrote the justification for the OPG, then really you should probably do it the report on it.
Thank you. Okay, let's finish on a really nice question. So, what is your favorite part about treating pediatric patients?
My favorite part about treating I just love how surprised you can be at how much children can tolerate and get through treatments that you just would never expect them to get through. And they're also, it can be very thankful, although a lot of them can be screaming in your ear sometimes. When it goes well, they really do appreciate it.
Yeah. Someone has just written in the chat, the challenge is the best bet.
Yeah, it is.
I think that sums it up with pediatrics, doesn't it?
Yeah,
thank
definitely.
you so much, Robbie. That was fantastic. If anyone has any further questions for Robbie, anything, you obviously put your details on before. I think you're Robbie Dental Therapist on Instagram, is that right? So
Robbie the
I'm
dental
sure
therapist.
you're happy for people to fire their questions at you if they have any
Any
more.
questions? Yeah.
All right,
go for
and we'll
it.
pop the list of references onto the group and whatnot. But thank you so much, everyone, for coming. Everyone is still on, so have a lovely evening. All right.
Enjoy, guys. And
Thank
thank you,
you.
Lauren.
And this will be available online within 7 days for anyone that wants to watch back. All right. Thank you very much.
See you later. Bye.
Bye.